Welcome to Lovesick Podcast, where we dive into health, wellness, and relationships, and their impact on the world. Come be a part of the discussion. Join our community by following us on YouTube, Instagram, and listening wherever you get your favorite podcasts. Enjoy the show. Welcome back to Lovesick Podcast. I am here with our usual host, Dorothea and Jada. And we have a special guest joining us once again, someone who probably needs no introduction, but who is the host of Ask Dr. Drew on Rumble. Dr. Drew, welcome to the show. Welcome back.
It's great to be here, guys. Thank you.
I know you're tired of me gushing over you, but every time I see you, it's like a mix of both my childhood and my professional life overlapping, and I just think to myself, what a wealth of information.
You know, it's so funny. I appreciate that, and I really do. But lately, there's something going on, something in the ethos where people come up to me all the time and want to express their. I almost don't know what the emotion is, but they're longing for a love line to return. That's sort of how they describe it. Like, and I have to kind of reorient them and go, no. You really don't want the love line back because it just wouldn't work. You want the 90s back. That's really what you're looking for.
Yeah.
90s.
Yeah.
You want that back. You want us as we were 35 years old. You want us to have that show in 1997. Okay, I understand that, but that's different.
Yeah, if people felt a little more innocent, a little kinder, maybe. felt like we didn't know.
God. And no Google, right? And so nothing. And so people had lots of questions, and we were that was the naive idea we had, was just help people understand stuff that I would have wanted answered to when I was a kid.
Well, I think maybe people still want answers because they Google it and get it wrong now.
Well, it's so you're putting your finger on something very important, which is the information is all there, but the confusion is still there. Also a problem. It just has a different kind of quality to it.
Yeah, and to that end, I want to dive into a part that you were so gracious to be willing to come on and talk about. We want to talk about men's health. Men's prostate health is something that people do not discuss enough. This is an area that I think people overlook all the time. And you touched on it last time you were here, but we really thought it would be important to come back and kind of, since you're willing to share your journey, and there is so much bad information.
Oh, yeah. Oh, no, I'm an open book about it. So I work with something called the Prostate Cancer Foundation. You can go to their website, pcf.org. Tons of information if you're worried about a family member or you yourself have been diagnosed. We're the sort of center of the universe of all things prostate cancer. And I myself have prostate cancer. I was diagnosed about 2010. 14 years ago. And I went on something called, I was picked up early. So I went on something called active surveillance, which was at the time we were doing recurrent biopsies. And I did that for about 2 years, and then it was growing, so they felt they had to really do something. And by then I was ready. At the beginning, it's like, you're not ready. It's like a really hard thing to, particularly at 50 or whatever I was. Yeah, I was 50. And I was like, oh man, my uncle had this, my dad had it. And so if it's in your first degree relatives like that, it's very likely it's going to happen to you. But they got it in their 70s. And I assume that's when I would get it. Then I'd get external beam radiation. It would be no big deal. When you get in your 50s, it's a different thing. And I can tell you more of my story from there. But the one thing that I have been gravely concerned about when it comes to prostate cancer are the populations. And the PCF is very much involved with this exact issue, there are populations that have more prostate cancer than average. And when they are diagnosed, the prostate cancer tends to be further along and more aggressive. And African-American men are definitely in that camp. And my patients, my black male patients, do not want to deal with this problem. They don't want to hear about it. And I really rely on sisters and moms and other women in the family to help get the men to get it together with their treatment, because there's no reason, no people should not be dying of prostate cancer today. It just shouldn't happen. We should be getting it early enough to deal with it, manage it, cure it, and there may be some follow-on whatevers, but deal with it. We have so much we can do now that letting it get away or diagnosing it at the time when it's too late is just heartbreaking to me.
Yeah, I agree. I couldn't agree more.
And I think, like, for women, when we have to test ourselves for, do our self-breast exams, is there an equivalent to that for males to regularly check? No.
Nope. It's a completely occult thing, has no symptoms. It's a blood test. You got to start those blood tests at age 40 if you have a first-degree relative with prostate cancer, and age 50 for everybody else. And I think a lot of men believe that somehow there has to be a digital rectal exam involved with it, which there does not. We can do it all with blood tests now. But once the blood test is positive, then we have to get on this. And there's lots and lots to be done. And because we're getting better at surveying and picking it up and imaging it, we're getting it early. We're getting it very early. And oftentimes it's just surveillance. Oftentimes it doesn't even require treatment. So it's nothing to be afraid of. And when it is treatment, I had a prostatectomy, a radical robotic complete prostatectomy, which back in the day meant you'd have erectile dysfunction and bladder leaking and all kinds of groovy things, of which I have exactly none. And it's interesting when I sat down with my surgeon and I said, all right, how many you done and what's the complication rate? He goes, well, I've done about 1,100 and so far 0. I went, okay, put me on the schedule. I can deal with that. 0 is just about right where I want to be. And I needed about 8 years later, my PSA kind of came back a little bit, so I had some radiation. And even that now has progressed. They have something called MRI-directed SBRT, which is this very localized radiation that has no side effects. I had 0 side effects from that either. And my PSA went back down to 0. So it's a good case in point of detecting it early, doing what you got to do, and then following up and then doing it again if you have to. And the thing gets really taken care of.
Well, I'm going to give you a huge compliment on my end, because after our last time you were here, I went and got my numbers tested because I was like, it's a blood test. I'm like,
there you go.
I'm a firm believer that these messages come to you when they're supposed to. And at first, the guy goes, oh, there might be something abnormal with you. And I was freaking out because my dad had prostate cancer. And he's like, no, you're good. He goes, somebody gave me the wrong one when I first looked.
Oh, no.
And I started laughing. But it actually was a blessing, right? Because it made me much more aware, and it made me like, you go through the steps. And I think one of the things that I want people to hear that you just touched on, I think the visual that most guys have is they'd rather not know because they think it's going to be the end of things that they love, or that it's going to be overwhelming. It's going to destroy their life. And the reality is you're living proof that this can be managed and everything can be fine.
Right. Oh, that is the most of the experience of our prostate cancer patients today, is that it'll be fine. We'll take care of this. We'll do what we got to do, and you're going to be fine. And let's not minimize the threat of what an operation is to that region of our body as men. It's going at what it means to be a man. I get it. I understand that it's very threatening. And then just the word cancer. I mean, when you get that word for the first time, it's really an interesting experience. You feel like you're going to fall through the floor. It's so funny. And my thing was like, really, at 50? God, 20? 50? It's not fair. And I was not ready for an operation at first. And again, prostate's a very slow-moving cancer. And I sort of said to myself, I got all this stuff going on. I'll do it in this end of the spring. And by then, I got a really fine group. I got involved with the Prostate Cancer Foundation, and they had some more conservative measures to do. I ended up with the operation, and it was great. And it was really a zero problem thing, and continues to be. And I come across lots of men that put it off, delay it, don't do what they need to do, and it's just then you are going to get into trouble. Yeah. Then the need for treatment is. Then you're looking at, maybe more radiation and maybe hormone blocking medicine and things that, you don't want to get into that, trust me. And if you get it early, none of that is necessary.
Yeah, it's options, right? The earlier you catch it, the more the options are. If you wait, the longer you wait, the less the options.
Well, the more the interventions are unpleasant, frankly, and who needs it? Why? Look, we can prevent that cancer from spreading and curing and hurting you, but who wants to be, a bunch of meds and things? I just forget. I don't want to do that. Yeah, I actually announced anyway. So I really don't want to do that stuff myself. I told my urologist, I'm like, if we get there, we're gonna have to talk about this because I want to consider some other ways of doing this. So,
I have a question.
Yeah.
Can you actually live without a prostate?
I'm here. I'm okay. I'm alive. I'm living. Mine is gone.
Okay.
They take the seminal vesicles. They take the prostate. But they leave the blood supply and they leave the nerve to the penis, and the challenge and what the robot has sort of improved our capacity to do is to preserve those nerves so they're not stretched or injured in any way, and then the bladder, which the prostate penetrates to get to the outside world. I'm sorry, the bladder penetrates the prostate to get to the outside world. That whole setup. The way hooking that back up is better than it used to be. So again, less leaking and those sorts of symptoms.
That's interesting.
What are the things that you wish people knew the most? What if somebody, especially somebody who's in their early 40s, right? What do you wish the average man would know?
Mm-hmm.
That prostate cancer, I think, is just behind breast cancer in terms of the most common cancers in the world. And if you are in a risk category, which I didn't mention the other risk category because I think they mostly know it, that group, which is Scandinavian men, particularly Norwegian and Icelandic men. They have much more prostate cancer, much more aggressive prostate cancer. And most people have relatives that have prostate cancer, so they're aware that they have to really, really stay on top of that. And then African-American men, that's the other population that I worry like hell about. We're not doing great. I keep saying the NBA should be doing, there should be groups. We got to do stuff where reach out and get to this because the level of awareness is just isn't there. And you said, Jada, you mentioned doing self-examination of the breast and stuff. As men, we are horrific about going to the doctor. All men. You guys get used to going in your teen years, for screening and whatnot. Mm-hmm. We got nothing like that. We don't start going to the doctor until way later in life. And usually the first time we go is because our spouse or family member drags our ass in there. It's not, we're not going on our own very often.
Or there's a problem that's been around for a while. Cause usually right away, men don't go. Men go, let me give this a while and see if it gets better. Or maybe after a while, it usually takes a spouse or a partner or a loved one who turns to you and goes, it's time. It's been time.
Yeah, no, listen, the women in the room are looking at you going, oh, it's so dumb. Because I know how you guys feel about it. It's like, really? You're really that dumb? But yeah, we really are. Yeah. And literally all of us think that way. All of us. We all go, if it's going to, let it kill me because I really don't want to know. You know what I mean? If it's going to kill me, it's going to kill me anyway, so fine. I'll just die.
I will vouch for this. Away. This is the truth.
Yeah. I mean, it happens with everything. Yeah. No, we talk about that a lot where it's like literally, this still hurts after like 5 weeks. I guess maybe I'll check it out.
Maybe. That's a maybe.
I mean, that is true. I mean, even with women, we go through a lot with different tests that we have to get. And I literally just came back from my mammogram just before I did this.
Well done.
So I just actually had that done before I came to the studio. And we just made a joke about it, saying, get it smashed. That's what I said to her. Yeah. But it's important.
By the way, if men had to go through that miserable experience,
no way.
You would do a much poorer job than women do. I swear to God.
Hey, it's hard enough to get us to go. If there was anything like that for men, medicine would go out of business if that were the case.
Think about the fact, here's why we don't go get our prostate screened, is because we still have a memory of the fact that they used to do a digital rectal exam. Therefore, we're not going to get the blood test.
Right.
Yeah. They don't want to do something to me.
Yeah.
Not that you're definitely going to get a part of your body smashed miserably.
and poor women, we take that as that's a normal, this is, you put it on your calendar and it's a normal thing.
Yeah.
And women show up. Like, that's also a compliment to the way women just kind of endure pain in society in a different way, because they just show up. Because men would be like, I got to cancel that. I have another option. Is there another place I can go? Hey, it's been lovely. Hey, doctor, you guys are really busy that day. You have more important cases. Like, anything to get out of it.
Yeah.
I wish it were just funny.
Right.
Unfortunately, it's not. You're
true.
right.
It's accurate. Yeah. It's true. And that's what we're fighting here, right? And so we have to make it trendy or something. I don't know what we do. I've been thinking about this for a while and I've not succeeded. And the best I've gotten to is to reach women in the various communities to get them to really work on their family members.
Right.
But even that, I mean, you guys are busy doing other stuff. You can't just worry about the men's health in your life.
And we're stubborn. It's hard to drag us, even if you can get to us. So,
oh my God, this is an ancillary topic, but the same exact issue pertains to erectile dysfunction, and the problem there is that men aren't aware that erectile dysfunction is often one of the earliest signs of heart disease. And so they don't come in for that. And we don't get a chance to screen them because they don't show up unless their spouse or whoever drags them in.
Wow.
Oh, I didn't know that.
Is there, just for the research side of it, is there like a known cause or any type of cure that's coming for prostate cancer?
Well, prostate cancer, it has not ever changed. It's a cancer that's been around forever, the same as it is now. It's not increasing or decreasing, particularly that I'm aware of. Anyway, I don't think so. But the medical relationship with prostate cancer has evolved dramatically over the years. When I was in training, prostate cancer was this sort of sleepy cancer that oncologists didn't even involve themselves with because it either was this slow-growing tumor that you lived with, it didn't bother you, you died of something else, or it killed you quickly and there was nothing we could really do about it. And that was it. And so you either had one kind or the other, and we kind of did radiation and whatnot for the slow version, and the fast version, we kind of threw up our hands. And so you didn't hear much about it, and people that died of prostate cancer died of it, and people that did okay because of radiation therapy just did okay and needed, follow-up and whatnot. It was not something that we emphasized because we didn't have as much to do. Now we have cures, we have treatments, we have so much we can do, and people are living with this tumor dramatically longer than before. So there's a lot of people around with prostate cancer whom would have died before that you would have been hearing from. I'm probably, if it had been 40 years ago and I got prostate cancer at 50, they probably would have done external beam radiation and it probably would have come back. And then I wouldn't be here talking about it. So that's, I think, why you're hearing more about it.
Is there a world because, when we go to the doctors, when you're like 40 or whatever, or a certain age, they're like, okay, it's time to start getting these mammograms when you go to your general practitioner. Is that the same when you're going to see a general practitioner? Are they like, it's time for you to see a urologist?
No, they kind of mention it, but it goes back to the male thing. And tell me if you disagree with me, Dr. Drew, is like, they kind of mention it in passing, or like, hey, we could add that to some blood work, but guys are very...
Okay, so is your doctor a family practitioner or an internist?
I've had both. So
okay, so there's a little controversy about how much to screen and how frequently and how soon, because there is a philosophy out there that people like me are screening too aggressively and therefore subjecting people to treatments that they maybe really don't need. This cancer wouldn't hurt them anyway, and it would have showed up later, and then we can deal with it later. I am not. That is not the deal. The numbers are clearly lining up to show that people like me are doing the right thing. But there are still people out there that want to be more conservative and say, I don't know, we'll start at 50 or maybe even 60, and we'll screen you. But as you get towards 50 and 60, you will get a PSA every year. That is routine screening as you get older. Younger, it's controversial whether we should be screening or not a little bit. And you also asked about treatment. I mean, there's so many amazing treatments coming. You know, the enzalutamide was a big breakthrough in treatment of the metastatic prostate cancer. But what's about to happen, when I saw this technology, I thought, oh, that's going to be the thing. But cancer is very smart. We have been really deep into the genomics of prostate cancer now, and so we're breaking down all the specific genetic mechanisms and what makes certain cancers grow and do their thing, and how many different kinds of cancers there are within prostate cancer. There's many, many hundreds, I would say. But there is a marker. So with the blood test that you get, that we've been talking about, it's called the PSA, the prostate-specific antigen. And there's even a more specific protein that is expressed only on prostate cancer cells called PSMA. And PSMA, we have figured out ways to direct imaging to that protein. So literally we can send little radioactive particles to the single protein and image the protein cells, the prostate cells, wherever they might be in the body. So we can detect these tiny, tiny presence of prostate cancer outside of the prostate, should it have gotten there. The other thing, and also we can direct radiation at it and other things and detect it way before it would have been visible before. But the more extraordinary thing, and this is the really interesting thing, is that we can essentially take radioactive particles and attach it to that prostate cell and instruct the cell to take it in, so we destroy every single cell. So every single prostate cell can get attacked by a radioactive particle that has, by the way, it's so low radiation dosage that it only kills the cell. It has no effect on the surrounding tissue. The problem is that prostate cancer is so damn smart, it learns how to downregulate the PSMA or to not take it in the way we want it to. It learns how to survive the attack we put upon it. So much like bacteria, which you act the same way, and much like other cancers, we have to figure out a way to attack it in multiple angles simultaneously so it doesn't genetically alter itself to create a mechanism to undo our attack. It's interesting, right?
Wow. It's fascinating. Look, nature finds a way, right? Even the bad sides of nature. And this is one of the things about medicine is we constantly have to innovate. Because the body, the thing that is attacking you is going to find its own way to fight back. And, it's kind of a biological warfare that's happening inside our body all the time.
Exactly right. It's exactly right. Once that tumor decides it's a tumor, it wants to survive. Even though the crazy thing is it destroys the whole system. It's a weird glitch. But that's and same with bacterium. They want to survive and they find ways and they share information. They have plasmids that go back and forth. And there's all kinds of and tumors do the same thing. They find ways of sharing information. So it's so to me it's breathtaking to watch biology at work. It's just so incredible. It's so. And this is one of the things I worry about when we talk about nutrition and things like that. Everything sounds like a story. This happens, then this happens, and it just is not how it works. Yeah. It's like trying to tell a story of how a cloud's going to behave. It's just kind of all happening all at once, and there's a probability of something going a certain direction, and you want to, understand the thermodynamic effect of those probabilities so you can understand what's happening and maybe go at it.
Yeah, always changing, always evolving, right? Always finding new ways. I think it's the thing about biology that's fascinating. And, it's one of the reasons I read medical studies. As strange as it sounds from time to time, they look at me like, when did you read that? But I'm obsessed.
I don't think there's anything wrong with that.
I think it's fascinating. You also touched on something from a personal advocate side.
Yeah.
You talked about how you're a rarity from the standpoint of people say that you're asking for too much screening. I don't know how you could ever screen or find cancer too early. I lean towards your side. I think we overestimate, especially when it's a blood test, right?
Well, I'm sympathetic to that point of view. That's why you notice I didn't attack it,
Right?
Because I'm by my nature somewhat conservative in my way I practice. I mean, I really feel that doctors don't pay enough attention to our mandate, which is do no harm, right? And unless we can prove that by screening early we are not doing harm, we are only doing good, or at least disproportionately doing good with the outcomes. There is evidence that we're doing too much radiation, a little too much surgery, a little bit too much this and that. Now, I would argue that was days gone by, and we're still sort of adulterated by that literature from 10 years ago. But I'm sympathetic. I get it. Do no harm is a very serious thing. And that's why I would warn you, too, when you read medical literature, make sure you read broadly, because things go back and forth, and then you'll kind of see a consensus developing. That's the biology, the cloud thing happening. You can't say things are all one. That's why I'm so pissed at the press for reporting things in medical literature as though that's it. Thus saith the Lord. Here's the answer, as research shows. No, research doesn't show anything.
Yeah, it's not a fact.
Produced 50 times.
Yeah, it's not a fact.
Maybe it's showing something. So, yeah, it drives me crazy.
I know every time, but everybody wants to be the authority.
Yeah.
And we do a disservice to everyone when we start acting as if all of these things are universal, because there are no 100% medical universals, right?
No.
The body is adjusting. You're adjusting. The environmental factors are changing. Biology is changing. Things are fighting. You know, it's never that cut and dry.
Well, it's why we have residencies and clinical training in medical school, because the biology and all the science stuff is all crammed into our head by the end of the second year of medical school, for the most part. What we do after that is the application. So we have the experiential learning of seeing how it manifests in human systems and developing judgment, not knowledge so much as judgment, so we can make the right call for the right patient with the right condition in the right context with the right medicine, the right dose, because it's our judgment that that's the right thing to do, not because there's some algorithm telling us to do it.
Dr. Drew, I want to ask about the insurance companies. What major part do they play in this decision making of why it's too much radiology or too much of this test or too much of that test, and then they won't pay for it?
Yuck. So,
I hit a nerve on that one.
Yeah. So I've been dealing with insurance companies my whole career, and it's been so frustrating and so problematic and so disheartening. And then a new layer has been added to that, which is now most physicians are employees of big hospital system and things like that. So they have bosses who are sending down what used to be called clinical pathways, which are algorithms. Exactly what I said we shouldn't be doing. And then the insurance company goes, aha, the hospital has an algorithm. Well, that's what we're going to cover. We'll only cover the algorithm that you, Dorothea, must fit into because that's just the way we decided. There's nothing special about you. There's nothing special about your doctor and his or her judgment about you. You're just another algorithm. That is horrific. That is the opposite of the practice of medicine. That is how we get into trouble. That is where medicine is right now. And it's gravely, gravely concerning. So I would say the most important thing, two most important things, is make sure you have a physician that gives a damn about you and is well-trained and cares and is willing to work with you to fight things when they come up, and be ready to advocate on your own behalf.
Wow, that's some good information.
I think that's what we talk about too, why some people just don't even get checked out because of like insurance, or will it cover it, or I don't have the right insurance, and so maybe it's going to be too expensive, and this is why I don't go.
And unfortunately, Jada, the fear of cost keeps people away from the medical system. And so just think about it this way. For somebody, if a Medicare or Medicare Medi-Cal patient to see me costs them nothing, first of all, but I get paid about $47. And if they don't come to see me or don't follow up with me and get sick and end up in an urgent situation and walk either into an urgent care or an ER, Just walking in the door is $2,500 because you have to pay for all that staff and infrastructure and equipment that they have to contend with. I've got my office staff, and Medicare controls everything we can and can't charge. It can be, and with telehealth these days, it can be done very cost effectively. People just need to do a little bit of homework and not be so scared that because you're going to end up in the ER. And then it is $2,500, or maybe, God forbid, a lot more. And it's completely unnecessary, completely.